Pharmacist, Mrs. Motayo, are you on board? You called me earlier.
Yeah.
Hello? Yes, you are on board.
Yeah.
All right. Can you share your slides?
Okay.
I hope you are a co-host.
Yeah.
Okay. All right. Once again, my apologies for logging in late. Good evening. Today is we're going to be having another educative meeting of CPAN, and the topic is Peptic ulcer disease. So good evening to the national chairman and all the CPAN execos and everyone on board. A very good evening to you. And our presenter today is Pharmacist Motayo Oluwatoyin, fellow of the West African College of Pharmacists, and she'll be doing justice to the topic peptic ulcer disease. Let us listen attentively so that we could either ask our questions or make our contributions. And for the sake of network and stability, I'll be switching off my Zoom camera. Let us listen, please. Mute yourselves. Pharmacist Motayo, you have the floor.
Thank you. Good evening, House. Starting on already existing protocol, Motayo will be presenting peptic ulcer disease.
Can you click on the slideshow?
You said?
Can you click on slideshow to make it bigger? Slideshow. Click on slideshow. Show. Yes.
Show.
And the icon there. Show. Make it big. Yeah.
Show is not down, here.
Is it down or up?
It's there.
Slideshow.
Yeah.
Slideshow.
Yes.
Slideshow.
Something like a TV. Just click on it.
Slideshow. I don't think.
So that it will make it bigger.
Yes. That's it. Just click on it.
Okay. Are you sharing from your phone or
no? My laptop.
The laptop. So at the bottom right.
Click on that one. Click on it. Click on it from the beginning. No, you see from the beginning. Click on from the beginning. From the beginning.
Okay, from beginning.
Yes. Okay, yes. That is good.
Yes.
Thank you.
Aha. There you are. All right. You can go ahead.
Okay. Outline. We'll be speaking on the definition, types of peptic ulcer, epidemiology, etiology, symptoms, signs, and so on. Definition. A peptic ulcer is a sore area or erosion on the lining of the digestive system due to secretion of acid to affect the lining of the digestive system and can cause problem to the patient. Types, we have the stomach affected, called gastric ulcer. Then in the duodenum, when it's affecting the duodenum, it's called the duodenal ulcer. Epidemiology. Duodenal ulcers are common than gastric ulcers. Gastric ulcer mostly occurs in people above 50 years, while duodenal ulcer occurs mostly in those below 50 years. 5 to 10% globally suffer a type 1 in their lifetime. Ulcer affects both sexes, and in fact, the Helicobacter pylori occurs as 9 in 10 patients having duodenal ulcer and 7 in 10 patients suffering from gastric ulcer. Etiology. A peptic ulcer occurs when the stomach acid damages wall of intestine or stomach due to increase in stomach acid or mucus coating is damaged. Major causes are long-term use of non-steroidal anti-inflammatory drugs, Helicobacter pylori infection, smoking, which can increase the healing time, then stress. Everyone knows that stress has one disadvantage or the other. Then signs and symptoms. Some may not have symptoms of mistaking it for indigestion or heartburn. Gastric ulcer symptoms, constant stomach pain or cramps worsening by eating, loss of appetite or weight loss, belching, nausea, vomiting. Duodenal symptoms, duodenal ulcer symptoms, pain in the epigastric or upper abdomen occurring 2 to 3 hours after eating, can be relieved by taking an antacid. Then waking early in the morning with a sharp pain above the navel, relieved by milk or eating. Then diagnosis, symptomatology can be used, endoscopy can be used. And that endoscopy, that's a diagram using a narrow fiber tube with a light optic camera at the end to pick this through the digestive system, pick the sample and check at the laboratory. You also have the urea breath test, which involves drinking a special substance that is normally broken down by H. pylori. H. pylori breaks down ingested label C urea, patient exhales label CO2. The blood can be tested, the stool can be tested, the tissue can also be tested. Then complications, we have many complications of peptic ulcer. There can be bleeding, there can be perforation, there can be anemia, there can be gastrointestinal pain, there can be blockade of the digestive system, there can also be vomiting. You can see from the diagram, the one with ulcer, the one with bleeding, and the one with perforation. Goal of therapy, relieve acute symptoms, return to full functional status, prevent relapse, improve quality of life. Then anti-ulcer medications, proton pump inhibitors, a group of medicines like esomeprazole, lansoprazole, omeprazole, pantoprazole, rabiprazole are most effective drugs available for ulcers. They block the action of stomach proton pump, reducing stomach acidity. They are used in combination with antibiotics to treat Helicobacter pylori ulcers. A2 receptor antagonists, a group of medicines like cimetidine, ranitidine, nisotidine. They block the action of histamine, which can release hydrogen ions, causing acidity in the stomach. Stomach linear protectors, we have the bismuth salt, sucralfate. They protect the lining from acid and eradicate Helicobacter pylori. Pharmacokinetics, oral bioavailability of proton pump inhibitors is high, 77% for pantoprazole, 69% for esomeprazole. They are metabolized in the liver by the CYP enzymes. The half-life is about 1 hour, but the duration of acid inhibition is high, about 48 hours. Then adverse drug reaction, misoprostol can cause diarrhea. Taking omeprazole for more than a year can cause bone fractures, gut infections. Rabiprazole can cause bloating of the face, arms, and lower legs, general feeling of tiredness and weakness, light colors too, unusual weight gain or loss, tingling of hands or feet. Then drug interaction, antacid cause delayed absorption with any other rarely absorbed drugs. Omeprazole decreases the absorption of clopidogrel, St. John's wort with Pain. Then rabiprazole may decrease absorption of ketoconazole or ampicillin. Treatment of Helicobacter pylori induced ulcer. Combination of medicine designed to clear the body of Helicobacter pylori, reduce stomach acid, and protect the lining. The medicines vary, but generally include 2 antibiotics to kill the Helicobacter pylori, e.g. amoxicillin, clarithromycin, or metronidazole, and acid suppressing medication, proton pump inhibitor. The medicines are normally taken for 1 or 2 weeks, and success is 90% of patients. Helicobacter pylori need to be cleared to stop ulcer from coming back. Adherence is encouraged for best outcome. Triple therapy, we have the triple and the quadruple therapy as it is being used. 7-day triple therapy, including omeprazole, clarithromycin, and amoxicillin, has become the treatment of choice for Helicobacter pylori infection. Also, the quadruple therapy is an alternative using the omeprazole, tetracycline, metronidazole, and bismuth salt. Patient education. The following are changes to lifestyle needed to reduce symptoms, but not treatment substitute. Restrict caffeine, avoid eating late at night, moderate alcohol intake, stop smoking, or reduce amount intake. References. Thank you.
Thank you very much, pharmacist Motayo, for the concise and straight to the point presentation. Now the floor is open for contributions and questions. Hello. Hello, house.
Yes.
Yes,
the floor is open for questions, contributions, observations.
Wow. Okay. My name is Pharmacist Chioma Okonkwo. I hope we can all hear me.
Yes, I can hear you loud and clear.
Thank you, Pharmacist Motayo, for the presentation.
Thank you.
We appreciate you. It's short. It's so short that, and you were flying. I wanted to draw back your attention to the triple and quadruple therapy. Please, can you slow it down a bit? Tell us about it. We still have so much time to digest this beautiful topic very well. Thank you very much. Apart from that, I don't have any issues with your presentation. It was a nice one. Thank you, ma.
Thank you, Pharmacist Choma. Yes, Dr. Peter Alphonsus. Okay, all right. Hello. Mota, can you hear me?
Yeah.
I think, will you note down the questions and then attend to them thereafter, or you want to take it one after the other as they come?
Maybe I should take it one after the other.
It's all right. So, Pharmacist Alphonsus, can you, I see 2 hands raised. Just patient, let her be through with that. Then the next person is, after that is Alphonsus. After Alphonsus is Dr. Anna Imoru. After that is Eugene, in that order. All right, go ahead.
Thank you. The triple therapy, you take the omeprazole 20 milligram, the clarithromycin 7 days, mostly, or it can be taken for 2 weeks alternatively. And the other quadruple therapy involves taking tetracycline to 50 milligram, metronidazole 400, omeprazole 20. Then the bismuth is the salt. It's taken an hour later. That's how it's been taken. In fact, the latest trend of treating ulcer now is doxycycline and one other antibiotic. But for the triple therapy that is being used, you need to take the omeprazole, clarithromycin, and that's how it's been taken. And mostly, you start seeing results from 2 weeks. Mostly, it's a week, 2 weeks, or it can be elongated for better outcome.
All right. Thank you so much, ma. I appreciate it. You rushed it, so I didn't get it. But now I get it very well. Thank you so much.
You're welcome. Okay.
Hello, Peter Alphonsus, are you there?
Yeah, hello. Good evening,
Hello.
all.
Good evening, sir. You're welcome.
Yeah, good evening, presenter. That was a wonderful presentation. But you were sounding more like a lecturer that was going to write exams for our students as soon as you finish lecturing. So we were your students this time around. We were listening to you, but you were actually making valid points, but you were actually rushing them. However, it was a good one. Yes. So I advise that next time when you are presenting, to professionals, even though you know you are fast and you know the stuff, try to slow down so that you go at the same pace with every other person. Some of us want to pick information, digest it, and use it. And as you speak, we'll be relating some of the things you are saying with our practice. So we'll be looking at what do we do with the information you have given to us? How does it apply to what we do? Are there 1 or 2 questions we'd like to raise? And people could raise 1 or 2 questions. I'm sure there are some people that you are so fast that they cannot even ask questions. Somebody has just asked a question and you answered it, which was good. So
I'm sorry, I don't even know the time. I was trying to meet up with them. I didn't even know how long. I was just told 15 slides. I just felt it's going to be so short that
you presented in less than 10 minutes by my own time.
I'm sorry. I was thinking it's 5 minutes. I didn't know. I was just like, I don't want the time.
This is the fastest presentation we have ever had. I've been following all presentations on CPAR platforms. I think
I didn't know this is my first time of attending and I'm presenting.
Okay, I see. I understand. So you are welcome.
Thank you.
Since this is the first time you are attending, probably that's why you saw it the
And
way you
I'm
saw
presenting. I didn't even know the time.
I understand. I have not missed more than 1 or 2 presentations since we started this CPAN meetings. So that's why I would reliably tell you that this is one of the fastest I've ever attended. However, it was good. Now, my area of practice is cardiology, cardiovascular pharmacy. So I like to approach it from that point of view. So when you look at the drug interactions we're supposed to look at, you didn't say much about it. Although you talked about clopidogrel and
no, the cardiovascular, I think it will reduce the potency of it, to reduce the absorption. Yes.
Yeah, we heard that. That was a good one. Clopidogrel, that's a significant one. I want to draw our attention to that place.
Yes.
As pharmacists, that is one thing we must look at for every prescription we see. You know, every prescription that comes in with omeprazole, we should always look at if they are, clopidogrel, and we could actually make our own contributions by advising whoever, the clinicians, other physicians, to probably switch that therapy to probably maybe vasoprene or salicylic acid, as the case may be, or any other medication. Outside that, now the triple therapy you talked about, there are drawbacks with the triple therapy, you know, and one of the drawbacks is in patients that have some chronic cardiovascular undertones. Most of these patients probably would have issues with the long time taking of clarithromycin. They could actually have this toxic de la pointe, or what is usually called ECG changes. So for those kind of patients, the pharmacists need to monitor them more closely. It will help actually the pharmacists to make their contributions. You actually said something about the long-term taking of proton pump inhibitors. Yes, long-time taking of proton pump inhibitors are associated with decreased levels of vitamin B12. And other vitamins, yes. Decreased level of vitamin B12. And so there may be necessary sometimes to take some of those supplements. Those are things that we should highlight when we talk about, disease, this ulcer disease, and probably the long-time use of proton pump inhibitors. And of course, that goes to mean that the pharmacist must be very close by to actually monitor. We shouldn't just be seen as people that just dispense the drugs, so to speak. We should actually have a lot to contribute and to say when it comes to this form of therapy. That is key. There are some other aspects probably that we would have wanted to say, but so that other people can actually talk or raise their own concerns or make contributions if they have, it will help. But again, I like to talk about there are more drug interactions when it comes to ulcer. Disease-drug interactions, apart from drug-drug. There are a lot of issues with disease-drug interactions. They are key. And one other thing I actually saw is that it appears you didn't give us any case study. Was it that you didn't find any patient that had ulcer?
I didn't know that when they say 15 slides, I was thinking it's going to be short. I actually wanted to, but I thought
it's okay. So that was my only question anyway. That was my only question. I wanted to know why there was no case study. Because that would have actually brought out some other aspects. We would have seen some things, people would have asked questions, and probably should have actually engaged us more as pharmacists, because that's one of the protocol of CPAN. We have it that when we do presentations like this, as much as possible, we should present cases. Thank you for the presentation once more.
You're welcome.
Thank you, Dr. Peter Alphonsus, for the wonderful contribution. All right, thank you very much. Dr. Anne Imoru, are you there? Anne Imoru.
Yes, good evening. Thank you very much.
You have the floor, yeah.
Motayo, thank you for this excellent presentation. Like everybody said, it's precise, and we would have loved a case study. But I have about 2 questions. I think Dr. Francis brought our attention to something, so that I would like to know what time interval would we advise now in the case of someone that is also on omeprazole and clopidogrel? What time interval?
I think an hour.
An hour.
Yeah.
hour is sufficient. All right. All right. Thank you for that.
You're welcome.
My other question is looking at the effective drugs you have listed. You listed omeprazole, omeprazole, rabeprazole, and some other proton pump inhibitors. What are the major differences? Because we have like some people that will come and specify this is the one they have. I mean, this is the one they want. Like maybe there's esomeprazole. The person wants esomeprazole. What are the major differences between? I'm not talking about the differences in probably structure or side effects, but like, is there any major differences in their own actions in the body? Maybe the clinical effect.
There is not much. I gave the side effect. There is really no much, but the mostly used is the omeprazole. But if you're considering the side effects, that's why you have to take another alternative. I don't think there's really no more difference with them. But the most commonly used is omeprazole. Others, they use it too. They use it.
Okay, so considering the side effect, is esomeprazole safer or lansoprazole? Is it safer? Is it less side effects with those ones?
Oh, they are okay. It depends on the side. Maybe if they use omeprazole and they're experiencing the side effect, they can switch to the other alternative.
Okay. Okay. So once somebody's on omeprazole and has side effects, you can now switch to probably esomeprazole or lansoprazole.
Yes.
Or rabeprazole.
Yes.
Okay. And then there's something that I've noticed that most times this H. pylori test does not, most times it comes out negative, but the person still benefits from taking the combination, that is the triple therapy now.
Most times.
Yes. Sorry. There was a statistic you mentioned with you said something about 90%. I didn't really get the statement you made.
That every 9 of duodenal ulcers come with Helicobacter pylori, and every 7 of the gastric come out with Helicobacter. Not all. We even said even in ulcers, some don't even have symptoms, and they still have the disease. Some can be mistaken for So I don't think it's a major. They might have it. They might have the disease actually. And it might be other, maybe, I think it's just like that, or maybe from the laboratory, maybe from the, I guess.
Okay, but would you advise, like, if the laboratory test comes out negative for H. pylori, the person should still go ahead? Because I've seen a lot of people that still go ahead and take
if just for a week or two and see, that's how it is. The fact that is negative or you don't have symptoms doesn't rule out that you don't have. Just try the medication. If you see improvement, then it's okay.
Okay. All right. Thank you very much for the presentation. Thanks for your answers. Very practical. Like we said, next time, please, we need a case study.
Yes, I actually
make
wanted
it more practical.
I wanted to. That's how I do things. So I'm sorry. Next time.
All right. Thank you, Dr. Anne. Are you done?
Yes, thank you.
Dr. Anne, you're all right?
Yes, I'm satisfied. Thank you.
All right. Thank you very much. Eugene, are you there? Eugene.
Yes, I'm around. Yeah.
All right, you have the floor.
Sorry.
Yes.
Yes, okay. Thank you, Pam Oluwatoyin, for the excellent presentation.
Thank you.
I think they've spoken most of the things I want to say. I want to draw your attention to the issue of case study. As a matter of fact, the education committee made it mandatory that all presentations should be accompanied by a case study.
Yeah, that's how it should be. But I didn't see much. At least I showed them the slide. They didn't mention anything.
Yes.
I just felt.
Because that will draw out a lot of things.
And next time, don't worry, next time, I have enough.
Secondly, I want to observe in practice, Most of the issue we have raised, or some of the text of the presentation, the triple therapy should be more guideline directed. If you look at most guidelines, they're talking about 14 days therapy instead of 7 days. Apart from that, if you look at the parietal cells, I'm not going fundamental now. We have both histamine and the cholinergic receptors. You find out sometimes if a patient is placed on triple therapy, they still come down with pain. But when you give them something like Buscopan, hyoscine, or Nospa, Dotavarine, they will do very well. And in the presentation, you never mentioned anything about the, I think, but they are still very important in our practice. You can give all the triple therapy, give all the whatever is recommended. What is important is the outcome.
Yeah.
And no mention was made about cholinergics, anticholinergics like Buscopan, their role. They have a big, very big role, or no spark.
You are right.
So I want to draw your attention to that. Yes, because sometimes you place a patient on triple therapy for 14 days. The patient will still come down with pain. And when you give maybe one shot of Buscopan or Nospa, it will be okay. You will say, oh, I'm fine.
Yeah, you're right.
Even after giving the Cimetidine and the Zantac, whatever.
Yeah.
So I want to draw your attention to that, please. And all of us do. It works. It works like magic.
Yeah. Yeah. Thank you.
Sorry to say.
Hello, good evening.
Yeah.
Okay, I think in addition to what Dr. Eugene has said, I actually think giving Buscopan, like you said, it actually works, and it makes sense that it would work. It's just like somebody is having malaria. You give the malaria medicines, at least before the malaria medicine starts working, you need to take care of the temperature, you need to take care of the headache. So the Buscopan kind of like serves as like a symptomatic relief. For that period of time, the person is experiencing pain while the drugs now do their work from behind. So I think that's the way it actually works. So most times you can't really give a normal painkiller apart from maybe paracetamol. So giving like paracetamol, Buscopan, or even Buscopan alone.
You know, I'm getting old now.
To relieve the pain. So that's just the mechanism.
That's 7 to 20. Do you have any small paper I can write it? Okay. I'm with it.
So I think that's just basically it.
You say it's 500 for.
Okay. Who is selling market? Or can you mute yourself?
Hello? Hello?
Hello.
Hello.
Can you hear me? It's all right.
Yes.
Is there any other question or contribution or observation? All right. I want to
hello. Sorry.
Okay.
Yeah, sorry.
Yes.
Sorry, please. I didn't know I was not muted. This is Eugene.
No,
yeah.
All right.
Sorry, I actually came in little late, so I didn't get all the presentation. But the person that asked question concerning the laboratory tests of Helicobacter pylori, and the fact that some of them don't turn out with the positive result. I just want to chip in that it depends on the lab, because I've had that experience. If you just send patient to any lab, you may end up getting a result that will also be anyhow. So what I advise is to make deliberate effort. If you have to visit some of this lab yourself and even check the equipment or the method they use, and then those ones that are reputable, you'll be sure of getting reliable results, because the ones I have used, the owner, who is a doctor in that field, actually handles some of those sensitive tests himself.
Yes.
And when the results come out, you are sure that is the answer.
Yes.
But if you get the ones that those lab scientists that don't really understand what they are doing handles, the results come out and it's neither here nor there. So you end up not getting adequate information to use in making your treatment. So that's just what I want to contribute.
All right. Thank you very much, Eugene, for that submission. Well, yeah.
You're welcome.
Can I say something else, please?
Who is speaking? Okay,
Dr.
Obi.
Obiachuru.
All right. Yeah. You have the floor.
Okay. I don't know. I was driving home at the beginning of the presentation, so I didn't really get a lot from it. But I don't know if the lifestyle modification, the counseling was covered during the presentation.
Yes, it was.
Okay, it was the things we have to tell the patients to avoid and all that.
Avoid smoking, avoid eating late in the night, avoid spicy food, blah, blah, blah. Avoid some drugs, NSAIDs, steroids, like that.
Do we have a slide for that? Do we have a slide? I was about asking. I was about asking you the same question, that I didn't notice the lifestyle modification. Okay, yes, I've seen it. I think I saw it just now.
Okay, that's it.
Can we see the slide, please? Okay. How about fizzy drinks? Did we talk about
fizzy drinks? Yes, carbonated drinks.
Carbonated drinks, okay. Peppery foods and the spices. Okay, we've talked about that. Okay.
Yeah.
What else now?
Okay.
Skipping of meal. Regular feeding.
Yeah. And in these days, you don't even need the diet. I think the patients are now free to take whatever. It's not all like before that it was planned, but now you can take to some extent.
I have a friend who has ulcer, and I know when we were still in the university, sometimes you just cook milk as a normal milk, and I'll be wondering, does milk play the same role with magnesium sulfate? Or
it doesn't. So.
Because I want to know the rationale. I was telling her milk was not correct, but she just feels, she tells me that whenever she takes milk, it alleviates her symptoms.
Yes, just to calm me, just for that to calm that, whatever, for that period. Just for
no
that.
Therapeutic effect whatsoever.
I mentioned it.
Okay.
You wake up with pain, yes, but just take it. But it doesn't take the place of treatment.
Okay.
Yeah, just for a relief.
Like taking water.
Oh, okay. I understand now. Thank you. I learned something tonight. Thank you very much.
All right. Thank you, everyone, for the wonderful contributions. Is the SIPA National Chairman on call? I can't seem to see his name here. Is he on? Hello?
No, he's not on. No, he has been trying to come in, but he's not been able to come in.
How about the National Secretary? Is she here?
No, she's not here either. I think probably she's busy at ARPS conference or something.
Okay. The Education Committee Chairman, Dr. Solomon, are you here?
No, but his secretary is here.
Okay. So secretary, I think,
Dr. Regina.
Okay, Dr. Regina. Maybe before that, Agada, do you have something to say? Hello? Agada, are you there?
I am.
Raising your hand.
You can go ahead, sir. Nothing yet.
Okay, it's all right. So I think, Dr. Regina, please, you have the floor. Hello? Dr. Regina, are you with us? I think maybe she's having network issues, so she seems not to be able to hear me. Dr. Regina James, are you there?
Hello, good evening, everyone.
Good evening, ma'am.
Yeah, good. We can't hear you.
Hello?
Yes,
Hello?
we can hear you now. Yes. Hello, I can hear you. I think we can hear you now.
Yes. Okay, I think I should pray. Hello?
Hello?
Not yet. Not pray.
Oh, network issue.
Right. I think hello? I think she's having issues with the network. All right. We want to. Hello? So I think it's safe to draw the meeting to a close now. Hello?
Yes, we can hear you. We can round up.
I want to thank Pharmacist Mrs. Motaya Oluwatoyin for this wonderful presentation rendered to CPAN National and all that are present. Thank you very much. We've learned a lot. Peptic ulcer disease. It sounds so common and it has been so common around us that we forgot some of the key details. But tonight, she has been able to bring it back to us. And I want to believe that each and every one of us that came here, we are taking something away with us. So at this juncture, I think let me call on. Is there any other national ESCO on board? Hello? Any national ESCO on board? CPA national ESCO?
Dr. Obiajuru.
Dr. Obiajuru should be here.
Are you still driving? The last time she spoke, she said she was driving.
I was
Dr.
driving.
Okay, so can you please end the meeting, say the closing prayers? Hello?
Network is bad.
In
While waiting
Jesus'
for the
name.
prayer, please send us the slides. We would like to see the slides. Thank you.
Okay, I should pause the slide.
No, Dr. Obi, can you end the meeting with the closing prayer?
Yes, I've been saying in Jesus' name. Can't you hear me?
Okay,
Amen.
we can hear you now. Amen.
Now. Okay, amen.
Yes.
Okay, Father
Amen.
in heaven, we thank you for today. We thank you for the knowledge you have imparted on us today. Thank you for the presenter. Thank you for the moderator. Thank you for everybody that was able to participate in today's meeting. May whatever we have learned today, oh Lord, help us to impact on our patients' lives. Also, to keep on improving our practice in Jesus' name. As we go to bed tonight, we ask you to please grant us a good night rest, and may we wake up tomorrow morning to praise and glorify your holy name in Jesus' name.
Amen.
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 Thank you,
Amen.
everyone.
Night.
Thank you. Good night. Thank you. Thank you, everybody. Thank you.
Thank you. Thank you.
Bye. Thank you.
Good night, everyone. Thank you very much.
Good night. Bye. Thank you.
Bye.
Bye.